All right, so we are going to talk about neurology. Just going to go through all of it. Hopefully, this won't take too long. So we're just going to try to go through some of the high yield stuff, things that I think could potentially be asked on an end of rotation exam. So the big thing is just knowing these three buckets. These are the primary headaches, right? Why are they primary? Because they cause themselves. They're not caused by like hypertension or like a brain tumor or something. So we'll start with tension headaches. Men equals women here. The I think the only thing that I've seen come up on like smarty pants questions is amitriptyline, amitriptyline, Elavil. This is a tricyclic antidepressant. All right, it's a TCA. How I remember this is you think of tension like not a balance beam, whatever balance tightrope, a tightrope wire that has tension, and then an elephant on a circus walking through that. So if you remember that Elavil elephant is amitriptyline. That's the most effective medication prophylaxis. There you go. Tension, amitriptyline. All right, migraines, what's important for these? Yeah, more common in women. These are going to be trigger based. You can get neck stiffness, visual aura is common, or at least the most common. There's a postdrome, there's a prodrome. So to make this chronic, more than half of the month or 15 days, and at least 8 of them are full-blown attacks. So I think that's pretty important, 15, because it's going to kind of help you with treatment. Do we go to a chronic treatment? So 2 weeks isn't enough. You need one more day, and then, okay, you have chronic migraines in a month. Pathophys here. Some stuff with glutamate. CGRP is always bad. Substance P is always bad. You see this with like fibromyalgia. Um, but yeah, vasodilating stuff is going to hurt. You think of like, this isn't really the path, but like cerebral edema, like swelling. So you kind of think of that like, so vasodilators are going to cause this. We'll talk about treatments for that in a second. All right, so cluster headaches. This is going to be, I'm tearing. It's a hot poker. It's right behind my eye. An explosive. I think you get these more in. Is this more in men? Yes. So men over women. Migraines are going to be women over men. That's why I have a picture of a guy here holding his hand. The big thing here with cluster headaches, oxygen. The acute treatment is not a medication. It's 100% oxygen, 10 to 12 liters. So that's like non-rebreather territory. And this is going to be because oxygen can vasoconstrict. That's the pathophysiology there. Okay. You can also use sumatriptan, which is triptan. These are migraine medications. And it's intranasal. You're going to put on the contralateral side of the headache. So if the headache's here, you're going to shoot it up the opposite side. And all right, so a little bit more with cluster headaches. Acute, you're having it right now. All right, we're going to give you oxygen. Okay. That doesn't work. Then we bring in the sumatriptan, okay, which we can do intranasally. Now we're transitioning you. You're in the hospital. We're bringing you down from this cluster headache. All right, let's give you some oral prednisone to take. And then I'm suffering from cluster headaches all the time. I need some maintenance. You're going to give somebody a calcium channel blocker, which is pretty interesting since it vasodilates. And we just said vasodilation, at least for migraines, is the path. System buffers. So whatever. I'm gonna try not to think about that too much. Actual patients. I mean, I know there's slightly different path here, but substance P, whatever. Just remember it. Calcium channel blocker, and this is verapamil, which is a non-dihydropyridine. So this is going to have some like rate control too. So it's a pretty strong medication to give somebody, and it's high dose. That's crazy. That's pretty crazy. A high dose calcium channel blocker. All right. And I've literally never heard of this medication in my life. Galcan, whatever. Second line option, interesting, lithium. I think knowing a calcium channel blocker is here for maintenance and knowing everything else, and that should be it. I made this little thing for the causes of migraines. It actually spells the word migraine. So menstruation, I is for eyes, visual stimuli. G is for growl, so missed meals. R is for reeks, which is odors. A is for alcohol. I is for the second I is for is it going to rain, which is weather. N is going to be nitrates. E is just emotional stress, and S is sleep disturbances. So take that for what it's worth. Okay, this is no pun intended, an absolute headache. I tried to do some memory palace stuff here. You're having a migraine, right? You're having an active migraine. Well, how do we treat this? If you want to start simple, you can just use NSAIDs. You can use things like Excedrin or Fioricet. Excedrin is acetaminophen, aspirin, and caffeine. Fioricet has butalbital in it, which I think is like a borderline opioid. You can use steroids. Yeah, no, anything that ends in triptan is going to be used here. Sumatriptan, rizatriptan. I don't really care about like side effects and stuff. Ergotamines, you can use this DHE. Antiemetics, this is something that like we've used in the ER, especially like Reglan, I think is really good for headaches, especially if there's, some associated nausea and vomiting. This too, Nurtec, I've seen used in the ER as well. And then Ubrelvy, I think I see commercials for. So remember what the path of CGRP is bad. So antagonizing that with the Gepants, these I think are worth knowing. And Lesmetidan, I've never heard of that. So anything else here? So serotonin agonist, that's what a triptan is. So it might be worth just knowing that's how those are working. Serotonin, that's Benadryl works with serotonin as well, right? As well as Zofran. The Zofran's not listed here. All right. How about preventative? So you have chronic migraines, which now is kind of not the classification of 15. This is greater than 4 per month. So that's probably more of an important classification. I don't, that's like, okay, it's chronic, whatever. But this is okay. Do you classify for preventative? You have greater than 4 per month. Or when you have them, they're greater than 12 weeks. I think knowing topiramate and valproate are important. When else did we talk about those? So I know they came up again. And I made a nice little chart with the anticonvulsants. Where else would that have come up? I think it might just be later in neurology. So we'll talk about that. We can get to that. Yeah, because we're going to talk about seizures. So I'm not going to worry about those at the moment. But I actually did have a little memory palace here. So valproates, I think about these like two sisters. So Val is the cool sister. She has these 240 ounces. So valproate is the one with the black box warning of liver impairment. That's actually really important. Val is bald and big. So valproate is, she's like the older sister. She's a little bigger. That's going to cause weight gain. And she's kind of like the ugly witch. So she's bald as well. Topiramate is the more like thin sister. Um, and she has her hands on her hip, so you can get kidney stones. That's a contraindication. And then, even though she's younger, she's a little bit dumber. She's like the hot, young, dumber sister. So topiramate is the one that's cognitive dulling. Oh, and she's Irish because she's saying top of the morning. So valproate, uh, you know, liver function, liver impairment, not good. That's why I have the alcohol there. Um, bald, weight gain. Topiramate is going to be kidney stones. I thought one of these made you, oh, and it makes you lose weight. Okay, there you go. Yeah, so that one makes you lose weight. Both of these are teratogenic. I think that's important. I don't think that one's important. So we have a calcium channel blocker here as well. And you can get gingival hyperplasia. Pretty interesting. I think of like calcium has to do with like your bones. Bones are near your gums. Obviously, like heart block, bradycardia, because you're giving somebody a non-dihydropyridine. Amitriptyline. So again, we're bringing things down from tension headaches and cluster headaches, and then the other TCA is nortriptyline, and then it's SNRI. I don't think that's that important. Yeah, the other thing too, I wrote this down as like an exam hint. Anytime you have a pharmacology question, look at all of the options here, right? There's a lot, but and there's all different classes. So you have to think about what is this patient presenting? They're throwing some vital signs at you. Are they a little hypertensive? Interesting. Okay, well, maybe I am going to start them on like a calcium channel block. Even though, I mean, that's these are more like heart failure stuff, but maybe they do have a history of heart failure, right? You want to put them on a beta blocker, you want to put them on a calcium channel blocker. Maybe they have a history of untreated epilepsy or something. And all right, we're giving them something, yeah, to treat their migraines. But if they've had seizures in the past, well, maybe giving them an anticonvulsant isn't a bad idea. Or they're depressed. So maybe breaking out an SNRI like Effexor isn't the worst thing to do. Or again, if they're depressed or they have like what like peripheral neuropathy or like fibromyalgia or something, then you can bring out like a TCA. So always something you want to consider of not only is this going to treat the migraine, because this is a neurology question, but what's the best option based on their history? So that's always going to be a good test taking strategy. All right. Status migrainosis. I still don't know what this is. So this is you have a migraine lasting greater than what's that, 3 days? That's insane. My gosh. Wow. This is where you use this DHE, or you can use, we're going to bring in valproate. So status migrainosis, we're going to use valproate. So that's the big and bald one with the liver impairment. Chronic, you can give Botox. I actually didn't realize that. But status migrainosis, valproate, I think is important. Okay. All right. These two, I still get confused. So we have occipital neuralgia, all about the entrapment of occipital nerves here. Tons of causes, including where are the occipital nerves? Like by the occiput? Spelled that wrong. Had no idea those were back there. Had no idea these were nerves and that these were back there. There you go. Okay. That makes this make a lot more sense. So patients will describe sharp shock-like provoking factors like cold temperatures, brushing the hair. You can produce this with Tinel sign, which literally is just tapping a nerve. So it's not just for carpal tunnel. Tap any nerve and it hurts. Tinel sign. So treatment is with NSAIDs or an occipital nerve block. Okay. Tic Delirium, trigeminal neuralgia, I think is pretty important. So you can also have things like brushing their hair, but like brushing your teeth, chewing, smiling, stuff with your mouth. Think of the trigeminal nerve, cranial nerve 5, where that's innervating. But this is also electric. So these are different, but think about where the occipital nerves are, and then think about trigeminal nerve, cranial nerve, where that is. So where they're feeling it, even though the triggers are similar, is going to be your hint here. Okay. Treatment here is carbamazepine. So that's a good one. So that's Tegretol. I forgot that was even a thing. Or oxcarbazepine. So Tegretol. I don't know that I would have remembered that. And that's for trigeminal neuralgia. All right, these both start with T's. So Tegretol, trileptal, trigeminal neuralgia. Cool. All right. Meningitis. What's important here? Strep pneumo is going to be the most common cause of bacterial meningitis. Neisseria meningitis is there too. It's in the name. Listeria can do it. You want to look out for that, especially with like pregnancy and with kids. The most common though is going to be this group B strep, strep A galactiae. Neisseria gonorrhea, you're going to have I feel like you don't hear about this one as much, right? Because that's not. No, I guess it is the same as the STI. I think I'm thinking of chlamydia because chlamydia has a couple different ones. Um, okay, so petechiae, palpable purpura. So you're going to get this rash here. Yeah, like you don't think of this potentially causing bacterial meningitis. I feel like we never talk about that when we're talking about like nephrology and stuff. Did I put that here? Yeah, so right, Neisseria is the meningitis one, but then also gonorrhea. So they're both Neisseria, but they both can cause meningitis, which is pretty interesting. All right. So this is where just meningitis in general, you can do Brudzinski, which is like a bra doing like a sit up with their head, Koenig's for kick. So flexing the hip to 90 degrees and the inability to extend the leg at the knee. I don't think this is really important. The big thing here is low glucose, high proteins with bacterial meningitis. So low glucose, high proteins is always important. You want to do empiric antibiotics within 60 minutes. The thing with meningitis too is you always do antibiotics first and then a CAT scan, and then you do the lumbar puncture. So if we're treating this, the most common is strep pneumo, and the treatment is a third gen Ceph, which isn't going to be great against strep pneumo, but is going to be great against Neisseria, right? Third gen Ceph, like ceftriaxone, is going to kill your gram negative. Vanco is going to kill your gram positives. So Vanco will kill strep pneumo and not Listeria. Listeria is a slightly different treatment, which I don't even know. Yeah, okay, we'll get that in a second. Bonus, if they have MRSA, you're killing that with the Vanco. And then use dexamethasone to like reduce cerebellar and cerebral swelling, especially for strep pneumo. If you know it's Listeria, so like your CNS comes back or you do an LP or whatever, you're going to switch to ampicillin, right? And ampicillin is just actually, this is the IV version. I just use the pill for any medication, but if I know ampicillin is the IV version of amoxicillin. And I actually learned that, you have augmentin, which is amoxicillin, and clavulinate, which is a beta lactamase inhibitor. The IV version of augmentin is, let me about this for a sec. Is it Unison? Unison, amsulbactam, because sulbactam is also a beta lactamase inhibitor. Again, my entire first year PhD school never put that together. The IV version of augmentin is Unison, which is amp sulbactam. because there's just the beta lactamase inhibitor. So anyway, pretty cool stuff. You're probably like, yeah, of course, like everybody knows that. Well, I didn't. And then if you want to cover for herpes meningitis, put in acyclovir. But yeah, listeria is AMP. And then I think if it's a kid for listeria, you give them gentamicin as well. Another important thing, and I feel like this comes up, is if there's a meningitis outbreak. So as a student, we have to get meningitis vaccines. So if there's a breakout, oh, somebody in a dorm, or well, not that I live in a dorm, but oh, somebody in a dorm had meningitis. I'm afraid I might get it. What prophylactic treatment can I get? You can actually use rifampin, the tuberculosis antibiotic. You can use Cipro. Cipro is going to kill everything, right? It's monotherapy for pneumonia. So it covers gram negative, gram positive. It covers atypicals. And then you can simply use ceftriaxone. So ceftriaxone is easy because it's already in this regimen. Cipro's kind of a curveball here, and rifampin especially too. So that would be a great question of like rifampin. Yep, totally for Neisseria meningitis. All right, what's over here? Viral meningitis. Yeah, whatever. You see lymphocytes for viral. You see what neutrophils more for bacterial. Whatever. Encephalitis. Most likely deficit is seizures. So brain abscess, you're going to get seizures. Brain tumors. There's just some quick high yield stuff here. Most frequent primary brain tumor is meningiomas. However, it's not malignant. Okay. I guess I should put benign. 90 to 95%. Mostly is going to be meningioma. So most meningioma equals most common. What's big here? An extra axial dural mass, homogeneous enhancement. Honestly, hopefully the pants question is just what's the most common? We're talking about something that's causing pressure in the brain. So dexamethasone, always good there. Seizures, you're going to use Keppra. All right, a glioblastoma is the one that is going to be malignant. This, you're going to see a ring-enhancing lesion. That's not like a pathognomonic term. You can get ring-enhancing lesions with like listeria, meningitis, but if they're asking about a brain tumor and you see that, and then you also get this central necrosis and clearing, so you see there's just this like black hole in their brain. So that's a glioblastoma that is malignant. Same thing, get the cerebral swelling down with dexamethasone, give them some Keppra. What is this? Primary CNS lymphoma. You get this if you have AIDS, you're going to get personality changes. Don't use steroids. That'd be a great question. No steroids for if you suspect a CNS lymphoma. And high dose methotrexate. Interesting. It's cancer, rapidly dividing cells. Methotrexate is going to stop rapidly dividing cells. So that actually makes sense. I wonder if you would give them like folic acid. Does that make sense? Oh, oh man. Oh, okay. Let's talk about strokes, I guess. Okay. Ischemic strokes. So some important stuff here that I always get tripped on is, they're going to check your neck and check for carotid stenosis. Important thing. If you hear a bruit or something, or if you have atherosclerosis, they're going to check your neck. Greater than 70%, we're taking it out. You're getting an endarterectomy. We're taking it out. Okay. That's for primary prevention. You never had a stroke before, greater than 70. We don't want you to have your first stroke. We're taking it out. Okay. If I've had a stroke, we lower that threshold. You're not making it past 50. You've had a stroke. Yeah, 50%, we're going to do an endarterectomy. Know those two numbers. I think that's really important. But you have to know one is for primary prevention, one is for I already had it. Now, if I've never had a stroke, knock on wood, and I have greater than 50, so still a threshold that's notable, just aspirin and a statin, just do preventative supportive treatment at that point. Okay. CHADS VAS greater than 2 warrants oral coagulation. Always a big pants question. Middle cerebral artery is the most commonly affected. It's right in the middle, easily enough, you know. And remember, we're talking about ischemic strokes. So an embolism is going to be a thrombus that comes from somewhere else, like the neck or like from the heart with somebody with AFib, which is why people with, that's like the number one cause here, why people on AFib are on things like Eliquis, blood thinners. So MCA, always a really good thing to know. TPA is 1 hour of arrival, but within 4 to 5 hours onset of symptoms. I mean, I would always check up to date on stuff like this, but that's always important. I don't know why it's 4 to 5. And 1 hour of arrival is just like, don't lollygag, like let's get going. But if they wake up with symptoms, even if they don't mention when they went to sleep, most people sleep more than 4 hours, and it probably took them like an hour to get to the hospital and get all set up. They're not a candidate for TPA. I miss that all the time. I'm looking through all the different criteria and how old are they, and they had surgery when, and they woke up with it. You can't give them TPA because you don't know when it started. Did it start an hour ago? It could have, or did it start when they went to sleep like 8 hours ago? So definitely something you want to always keep in mind. CT head without contrast, the reason you do this is to look for a bleed, right? Is this a hemorrhagic stroke? Okay. You do want to allow for permissive hypertension. I've seen this in my internal med rotation, which I just finished today. All right. If they are receiving TPA, we want to keep things under 185 over 110. So 85 over 110, 185 over 110. I always try to just remember the second number. So 85 and 10, and then obviously throw a 100 in there. If they're not receiving TPA, we let this go a little bit higher, right? Because TPA is going to fix the issue. Let's bring the blood pressure down. We're not going to fix that issue really quickly with TPA. All right, let's allow for some more permissive. So it's just 20/20. No TPA. Okay, let's keep our 20/20 vision. I like that. Keep our 20/20 vision on the prize. Whoops. Keep your vision 20/20. There you go. Otherwise, 185 over 110. All right. Yeah, this is always good. So this stuff, not as much. Motor weakness is frontal. Sensory is going to be parietal. Um, that's where you have Broca's aphasia. These are on the left side, right? I'm pretty sure. Wernicke's aphasia. Broca's is bark. So that's where you have you're just kind of like mumbling, and Wernicke says what, which you can't understand what's happening. So Broca's aphasia, you don't, from what I understand, you don't know that something's wrong. Wernicke's though is wait, Broca's you do know something's wrong because you can listen and you can hear. You're like, why am I talking like this? Wernicke's, though, you don't know anything's wrong because you can't really hear or process yourself. So I'm pretty sure that's right. Where else did we talk about that? He says, what aphasia? Would that have been anatomy? Fall anatomy final? All right. So Broca's bark will have agrammatism, simple incomplete sentences. Sentence structure is off and sparse output. Noise instead of words. So like they're barking. So you can say sentences, but a lot of times they're just mumbling and making noise. They can formulate it in their head, but they can't speak them. So they're aware and they appear frustrated. All right. So Broca's bark, problem with speech. Now we move down here for Wernicke's, which is in the temporal, the left temporoparietal junction. And these are right next to each other. So even though they're technically in different lobes, these are like right next to each other because one is in the back of the frontal lobe, one is in the front of the temporal lobe. So Wernicke says what? A comprehension issue, receiving sensory input, but can't turn those into their word representation or what the sound actually means. Speech has normal rate, rhythm, and grammar, but it's a meaningless word salad. So Wernicke's equals word salad. So it's not like Broca's is just mumbled a mess. It's noise. Wernicke's is words, and they have like that kind of rhythm to it, but like it doesn't make any sense. And you're like, what are you saying? And they're like, "Blah," and they don't look or appear frustrated. All right, so that's good. That's a nice little review. Even enough frontal is motor and parietal is sensory. Because yeah, I totally remember that. All right. I don't have enough room. Okay. The other thing that is important is by vessel. So for whatever reason, the A is first for ACA, and I always think laugh. So that's legs more affected over arms. Yeah, laugh. So legs over arms and face. So you're going to have leg weakness over arm and face. Um, as you move down to MCA, it's going to be the opposite. It's going to be arms over face or leg. And then posterior, and think about, and people making noise. This is, there's like the homunculus and everything like that. But anterior legs, MCA, arm and face, and then PCA, when we're in the back, that's going to be more in the cerebellar area. Oh no, I guess not. You'll have sensory issues. They always talk about like a thalamic stroke is just pure sensory loss. Yeah, okay. Um, High dose statins are always important. If they're an alcoholic, you actually put them on B1, thiamine, and I think B12 too. Maybe even folic acid. Like you pump them full of B vitamins. And then post-stroke depression. This is like a random thing that comes up, but fluoxetine Prozac and SSRI has been shown to help with post-stroke depression. So that's a good question. Okay, now on to, all right, we'll do hemorrhagic and we'll take a break. All right, intracerebral hemorrhage. What do you need to know about this? Hypertension is the big risk factor. Happens in the putamen, wherever that is. This involves lipohyalurosis of small vessels and the breakdown of vessel walls. So I think that's just like from like having high cholesterol. Presentation, whatever. Therapy, systolic BP goal 140 to 150. We use nifedipine or we use labetalol. Why are we using these medications? So nifedipine, which is procardia, is a dihydropyridine calcium channel blocker. So it's going to be a vasodilator. And if hypertension is the cause, makes sense. And then labetalol is a non-selective beta 1 and beta 2 antagonist, and it is a alpha 1, I believe it's an alpha 1 antagonist as well. I just created this. Maybe not. Oh, no. Beta law. Yep. Alpha 1 antagonist, beta 1, beta 2 antagonist. But I think we're really using that because we use this for hypertensive urgency and emergency. We're really using that for its vasodilation properties, which we get from the alpha 1 antagonist there. So that's why we're using that. We can manage intracranial pressure with hypertonic saline or mannitol. So why would we use hypertonic saline or why would we use mannitol? Is that like another name for this? So hypertonic saline, you put salt into your blood, water follows the salt. So fluid is going to flow from your cells and from your interstitia into your blood vessel, right? So it's going to take pressure out. And why is that a good thing? Well, because if you're hemorrhaging in your brain and there's increased intracranial pressure, we want to get fluid out of that. We want to lessen edema. I wonder why you don't use, I was going to say why you don't use steroids, but steroids would worsen your blood pressure. So they would help with like cerebral edema from like brain tumors and stuff, but they would you can't give somebody cortisol if they have hypertension. So that's why you don't use like dexamethasone. But hypertonic saline, pump the blood full of salt, pulls water out of the cells in the interstitium, will reduce that cerebral swelling. And then you are basically going to urinate out the fluid that was in your brain. Pretty cool, right? Okay. Subarachnoid hemorrhage, you definitely want to know just a ruptured aneurysm is the big thing here. Berry aneurysm. This is going to be that thunderclap headache, worst headache of their life. They could have sentinel headaches leading up to that. So look for that in a vignette. Never heard of Terson syndrome. Cerebral angiography, elevated opening pressure, xanthochromia, which is like, it's not like yellowish, pinkish. We can also use, okay. So instead of nifedipine, we're using nicardipine. What difference does it make? These are both dihydropyridines because verapamil and cardizem are the non-dihydros, right? Not this one. Where's calcium channel blockers? I just did this. Yeah, nifedipine, nicardipine. Yeah, these are just vasodilators. But what stands out here is nimodipine. Never heard of this medication. It prevents vasospasm. So nimodipine, definitely unique. Used to treat symptoms resulting from a ruptured blood vessel in the brain, like a subarachnoid hemorrhage. I wonder if this, yeah, it is a calcium channel blocker. Nimodipine never comes up anywhere else other than this, other than subarachnoid hemorrhage. So could potentially be pretty important. And then you can also use hypertonic saline or mannitol here. Okay. Always a question. I think there were like two of these on the pack rat. So subdural hematoma, which is going to be your crescent shape, and then your epidural hematoma, which is your lens or your football shape. That's usually the question. But the other thing, and you want to look for this on vignettes, subdural hematoma is all about the bridging veins and these cortical arteries. So you're going to see this in the elderly just due to cerebral atrophy. So it just kind of happens. But with an epidural hematoma, this is going to be more with trauma. Still could be an older person who has pre-existing conditions, but they fall, they fracture their skull, and then there's an injury to the middle meningeal artery, which is literally like glued to the inside of your skull. This sounds like it's something in your brain, but it's not. It's like right on that inside of your skull here. That gets injured, and then you get the epidural hematoma. All right. So you do a CT head without contrast for both of these. Lens football shape. You get these like lucid intervals, whatever. Knowing the shape and knowing what like mechanism of action would lead to that is going to be important. Okay. That's Neuro 1. Only 11 more PowerPoints, right? This is probably going to be one I have to do in two parts, unfortunately. So let me take a little breather and then we'll come back. All right. So let's talk about delirium and dementia. So delirium is an acute confusional state that fluctuates over hours or days, and it is reversible. Can also just be called encephalopathy. Okay. UTIs in the elderly, very common cause of this. Pneumonia, any type of like hospital sickness, the elderly can just get delirious, right? Benzos, obviously, opiates, alcohol, anything, that'll lower or depress you. Um, Hypoglycemia, hyponatremia, thiamine, B12 deficiencies, any type of, electrolyte issue. Hallmark symptom is a deficit in attention. Asterixis. Yeah, nothing crazy there. Yeah, chemical restraints, Haldol. Okay. All right. Then we'll work into like Alzheimer's dementia versus dementia. So let's talk about normal dementia. This is just an acquired chronic deterioration in cognitive abilities that impairs the performance of ADLs. You want to consider reversible causes first, like a B12 deficiency or even hypothyroidism. Yeah, interesting. That is like neuro stuff like that. Thyroid, always surprising me with thyroidism. High TSH. Slowed reflexes. Bradycardia, puffy hands and face. How about the myxedema coma? I mean, you can get hypoglycemia there. I don't know why you would get, I mean, I'm sure it's possible. I just don't have it listed. It can cause a B12 deficiency, which is pretty interesting. All right, whatever. Um, you get the mini mental status exam. So 24 for 24 hours of the day. If you get less than that, it's going to be dementia. Mocha. What's the, wow. These, oh yeah, mild cognitive impairment. So slums is always a good one if you're just trying to pick up something that's mild. That's going to be slums. All right. So slums, maybe you can think of like slum, like slim. So mild, it's just like that. Mild, a little. Pseudo dementia, don't really. Yeah, okay. All right. Alzheimer's dementia. This is a neurodegenerative disorder. So this is just like a memory deficit is the hallmark of dementia and attention deficit. So attention for delirium, memory more for dementia. Yeah, it's just getting old, I guess. And it's not like diagnosed as Alzheimer's. So early onset would be less than 65. Yeah, the most common cause of dementia is Alzheimer's dementia. So all Alzheimer's dementia is dementia, but not all dementia is Alzheimer's dementia. Recent memory is affected first. Then you have all this path. You have senile plaques, you have beta amyloid, you have neurofibrillary tangles, amyloid precursor proteins. I think that's important, like beta amyloid, senile plaques. You have these tau and ubiquitin proteins. So that's what actually a neurofibrillary tangle is. So all of this stuff is Alzheimer's. Um, MRI, you can do these like PET scans, these SPE CT scans. That's actually pretty crazy. Never would have remembered that. So we'll get into treatment in that in a second. All right, vascular dementia, the second most common. This is by a bunch of lacunar infarcts and chronic ischemia. You're going to see difficulty with executive function like time management, like keeping their schedule. MRI again, you're going to get white matter lesions, which you can get with like preeclampsia, white matter lesions. Where else did I see that? Something with preeclampsia is jumping out at me for that. I don't think it's like an MS thing. That's unreal. That's exactly where it is. I remember that because I used a memory palace and I put that on a windowsill in a room that was preeclampsia. So white matter took me right back there. I mean, that's white matter hypodensity. What does this say? It's got to be the same thing, right? Telling you, memory palace, so powerful. Okay, that's crazy. I'm proud of myself for that one. All right. I didn't have a memory palace for this stuff, so I didn't even know vascular dementia was a thing until just now. All right, frontotemporal versus Lewy body, I think is pretty interesting. So frontotemporal, early alteration of personality, behavior. You do get tau protein inclusions. So tau and ubiquitin you get with Alzheimer's, you get tau down here. What's like the big hyperorality, a preoccupation with oral sensations, and blunted emotions, a lack of empathy. So I think that's pretty important. That definitely jumps out. Somebody's like, yeah, I just don't care. Like they're not really reacting to anything. This was like fronto. Fronto is more like motor, isn't it? Got like a mouth on there. Treatment is going to be just SSRIs here, so nothing crazy. Or you can use antipsychotics. Lewy body dementia, a type of degenerative dementia with inclusions called Lewy bodies. They're made of alpha synuclein, which build up in presynaptic spaces. Amyloid plaques can be seen as well. And this is going to be, yeah, more visual hallucinations, more REM sleep disturbances, Parkinsonism. And this you're going to use an acetylcholinesterase inhibitor, um, which I think we'll get to treatment in a second of what those actually are. Yes. And then melatonin or Klonopin, a benzo for sleep. Okay. So in terms of treatment for Alzheimer's, you have these NMDA antagonists. So they're going to block glutamate receptor sites. And these are better for mild to severe Alzheimer's. So I guess a little bit worse, you're going to use something called memantine, which is called Namenda. Big side effect here is simply dizziness. So if you have somebody who's a little older and maybe a falls risk, is this really what you want to give them? All right. Then we can come over to the acetylcholinesterase inhibitors, which wouldn't you give that to somebody with, wouldn't that be a good thing to give somebody with uh, myasthenia gravis, right? I mean, we'll talk about that later, but this is going to be donepezil or Aricept. It's an 8-week trial. This is better for mild disease with a small benefit for advanced. If they worsen after discontinuation, put them back on it. All right. And a big side effect here is symptomatic bradycardia. So don't use it if a patient has a cardiac conduction disease. Symptomatic bradycardia. Wait a minute. Did I just make a connection with myasthenia gravis? I know I saw that somewhere. I hope I spelled it right. Yeah, so you use an edrophonium test, which is an acetylcholinesterase inhibitor, which you use for myasthenia gravis, but it can cause bradycardia. Holy crap, look at that. That's that was pretty cool. And the treatment for myasthenia gravis is there's some weird stuff there. I would know it if I saw it. It's a combination of like two band names. Um, I don't think it's IVIG or plasmapheresis. Azathioprine, Mestinon. So yeah, Mest and Mastodon. So Mestinon is what I was trying to think of. Cellcept. Oh, okay. IVIG plasmapheresis. They are up there. And a thymectomy. Okay, sorry, we're way off topic. So yeah, so look out for that. I don't know. I think donepezil and memantine. Those were both on the top 300 list. So those are good to know. Behavior, whatever. I don't think that's very important here. Aducanumab is you're going to cause amyloid-related imaging abnormalities leading to vasogenic edema or even microhemorrhages. So this is mostly used in research settings. And vitamin E, that's pretty interesting. Which vitamin is has been shown to have antioxidant properties for dementia. Vitamin E never would have gotten that in a million years. However, I do remember that from my ACE vitamin document, E does have a lot of neurologic stuff when you're deficient in it, so that makes sense. If you have too much vitamin E, you bleed because vitamin E bleeds and vitamin C clots. So E for bleed and C for clot. So, okay. NPH actually had a potential case of this in my internal medicine rotation. This is going to be your wet, wobbly, and wacky, wobbly, wacky, wet. So you're going to have a magnetic gait, which is a shuffling gait, little to no separation of the feet on the floor. Wacky is just dementia, and wet is incontinence. This is a problem with the absorption of arachnoid granulations. So you have impaired CSF absorption. So do you have too much? Yeah, hydrocephalus, impaired CSF absorption. Yeah, excessive CSF volume. There you go. And increased ventricular size. Treatment here is just going to be like lumbar punctures, or you can do a shunt. You drain and then recheck with an hour. If they can suddenly walk better, then you've made your diagnosis. So serial high volume CSF removal or these ventriculoperitoneal shunts. That's normal pressure hydrocephalus. Prion disease, which is Creutzfeldt-Jakob sporadic, is going to be the most common. Think of like spores in your brain, most common. Um, you can get it from contaminated corneal implants. Holy crap. I wonder if they make them from animals. Yeah, this is deadly. There's no treatment here. Mad cow disease, rapid onset, upper motor neuron symptoms like hyperreflexia, rigidity, cerebellar findings. You can do a real-time quaking induced conversion test. So, which of the following conditions is diagnosed with a real-time quaking induced conversion test? That's going to be prion disease, and it's going to show increased proteins. Okay. Honestly, I'm kind of out of steam, so I'm going to call it here, and then I will do the rest at another point. So I will see you in the next one.